Good evening, everyone. We're going to go ahead and get started. It's going to be a small group, so we'll have plenty of time for questions and answers, which will be great. I'm Denise Vigno, and welcome to Suicide Risk and Prevention. Nice to see you. Beautiful building for those of you who haven't been here. And I want to thank our sponsors, VCAM. We have Bill behind the screen there and Joey up in the audience, so thank you very much. Thanks to Jerry Riley Real Estate, and thanks to Dealer.com for hosting us. Tonight we'll do 45 to 60 minutes of presentation, and then we'll go ahead and have hopefully a good amount of time for question and answers. Just need my glasses. And I'd like to introduce my colleague, the wonderful Charlotte McCorkel, sitting here on the stool. And Charlotte's been with the Howard Center as leader in the Children's Crisis Program since 2008 for First Call for Children and Families. In July of 2015, she became the Director of Crisis Integration as we're merging our 3 distinct crisis teams. Charlotte holds a Master of Science in Social Work from Columbia University and an undergraduate degree from the State University of New York College at Geneseo. She's a member of the Vermont Suicide Prevention Coalition and the Vermont School Crisis Planning Team. Additionally, Charlotte was selected to participate in the 2014-2015 Addressing Health Disparities Leadership Program through the National Council of Behavioral Health. She's passionate about suicide prevention, disaster response, and the intersection of public health and mental health. So welcome, Charlotte.
Thank you. Thanks for having me. It's nice to be here. So I wanted to start by talking about, to give some background about suicide prevention and Howard Center's commitment to this topic. Within the First Call for Children and Family Crisis Program, we've been doing suicide prevention trainings and outreach in many different ways for a number of years, close to 2 decades that First Call has been a program. And we do that by doing suicide prevention when we work with clients and families, but we also do outreach to all schools in Chittenden County and then different community groups to provide trainings either to a small group of staff or to the whole school staff and faculty related to suicide prevention for the specific age group that they're working with. In the past year, Howard Center has become a pilot for the Zero Suicide Project. This is a national model of suicide prevention, and we're really excited to be piloting it here locally. It has many different components, but the biggest component is training clinicians in the field, both within Howard Center and in the community, to have increased skills in managing a suicide crisis so that clients and community members can get the best care possible when they're in such a crisis and connect to treatment and a comprehensive safety plan. And then additionally, Howard Center participates in the Vermont Suicide Prevention Center, which is hosted by the Center for Health and Learning, and myself and a number of other staff participate in the Suicide Prevention Coalition, which meets quarterly with stakeholders throughout the state, including law enforcement, educators, mental health providers, medical providers, to come together to talk about this important topic and the efforts we can make in Vermont. So tonight we'll talk about understanding the problem of suicide and available resources. Before you leave, I'll make sure that you have a really helpful app related to a suicide crisis that's free and I think really exciting and accessible, and then some key crisis numbers, both if you live in Chittenden County and also national numbers. We'll talk about risk factors, protective factors, and warning signs for suicide, which are really key pieces of information to be aware of in order to identify who might be in a suicide crisis. And then we'll talk about a 3-step intervention in order to help someone, and also self-care strategies so that you can help yourself. And in thinking about suicide prevention, this could apply to your professional context. It could also apply to your personal context if you're supporting family or neighbors or supporting others as a community member. So there are lots of different applications here. And when we talk about suicide prevention, a lot of what we talk about is applicable across the lifespan for children, adolescents, and adults. And there's some specific information, and I'll highlight that as we go, but a lot of this information is truly universal. And I just want to mention that in my work, I talk about suicide every single day, and so it rolls off my tongue pretty easily. But sometimes I refer to suicide as the S word, because it is a hard topic for people to talk about, and hopefully it's not typical that you're talking about suicide in a professional or personal context day to day, unless you're in the mental health field. And so I do think it can be a hard topic, and it can bring up things sometimes expected or unexpected, depending on our personal histories. So tonight, and just in general, certainly take care of yourself as we're talking. Take extra good care of yourself this evening. I think being more comfortable talking about it is one of the hopes for tonight, and understanding that it's okay to talk about suicide, it's okay to ask about it, and in doing so, we're reducing the stigma around it so that it's not such a mysterious topic and feels so secretive, but can be more open and shared so that people feel okay identifying that they may be in a suicide crisis and connecting to help. And so the first thing that I want to talk about is preferred language related to suicide prevention. There are two groups that have contributed to these recommendations about language. One is survivors who have survived a suicide attempt, and the others are survivors of a suicide loss, groups of people who have lost a loved one to suicide. And so both groups have different advocacy nationwide and also locally, and they've requested specific language to use to reduce stigma and to better understand the issue. So we're asked to avoid the word committed when we're talking about suicide, which is, of course, what we typically say day to day and what we hear in the media. So the word committed has lots of different connotations. People commit crimes, they're committed to life sentences. And then on the flip side of that, we want people to make good commitments. We want them to commit to a job or commit to a project or make healthy commitments. And so we don't want to associate the word committed for either of those contexts with something like suicide. Similarly, completed is a word that we're not asked not to use. And then certainly nothing related to suicide is successful, so to avoid using that when we're talking about someone who's died by suicide. And so the preferred language is to say that someone died by suicide or took his or her own life. Certainly shifting our language takes some time and practice. Sometimes even within the First Call program, clinicians are kind of stumbling over their words or resorting to previous language because that's what's comfortable to us. But the more we can practice and remind each other to especially avoid the word committed and to try saying died by suicide, that would be helpful within the context of the community. And so just to give some context, I'll talk a little bit about data to understand the issue, both locally in Vermont and then nationwide. In 1999, the Surgeon General at the time, David Satcher, gave the first call to prevent suicide as a public health effort. And so this rose the platform for suicide prevention to become as important as preventing drunk driving or wearing a seatbelt or obesity prevention efforts, and really shifted the conversation. And when we talk about suicide as a public health concern, then we can really focus on the idea of prevention and also treatment. So nationwide, more than 42,000 people take their own lives each year. And Vermont has the highest suicide rate in the Northeast and the 7th highest in the country. These are not ranks that we're proud of, especially when we're often considered to be one of the healthiest states in the country. The suicide rate in Vermont is higher than the number of deaths from motor vehicle accidents, homicides, and drownings combined. In terms of our national data, Vermont ranks 50th in a list of 142 countries for suicide rates. And interestingly, it's kind of hard to figure out why some countries have really high rates and some countries have really low rates. So certainly culture or religious beliefs or what's going on in that country could be a factor related to the suicide rates. But then the other thing is because of the stigma, there's often underreporting in what actually counts as a suicide. So all of this data about suicide deaths are when a suicide death has been confirmed as a suicide. And so there could be someone who dies where there could be unknown information, and that wouldn't be counted as a suicide death. That could be counted as an accident or unintentional injury. So for some countries, depending on how their statistics get reported, they could be underrepresented. Nationally, more males die by suicide and more females attempt suicide. While this may contribute to gender stereotypes, the reason behind this is that males turn to more lethal means, especially firearms, in a suicide crisis. And 90% of people who die by suicide have a mental health diagnosis, and most frequently that's depression. But there are other mental health diagnoses that can contribute to increased suicide risk. And then there is that 10% who doesn't have a diagnosed mental illness and is still at suicide risk. And what's important to note here is that sometimes this diagnosis happens after the death, where when information is gathered, it's realized that a combination of symptoms is such that depression was there. And so it's really important when we talk about risk factors to be aware of some of these early signs that could lead to mental health diagnosis. Just a few other data points in understanding the context of suicide across the country. Research shows that 90% of people who have serious suicide attempts and survive do not go on to have additional attempts. And this research is done by departments of health throughout the country that actually track how people who have had a serious attempt end up dying, sometimes often decades later, and they see it's from cancer or from another illness and not from a suicide. And there has been a study of people who have jumped from the Golden Gate Bridge, which is of course a very lethal method for suicide. There's a small number of people who have survived that, which is incredible. And longitudinal research has shown that those people have not gone on to have additional suicide attempts. And many of them received treatment and went on for full recovery. And then these other two data points here are a big reason why we're so invested in the Zero Suicide pilot project. 50% of people who die by suicide saw their primary care doctor within 30 days, and 30% of people who die by suicide saw a mental health professional within 30 days. This research is really important, and what it shows is two things. One is that people who are in a suicide crisis are help-seeking. They're going to their primary care doctor, or they're going to a mental health professional. And then the research from there is inconclusive, but there's some theories about what's happening next. It could be that someone was hoping for a prescription or kind of an easy answer for what was going on to help make it better and didn't get that result that they were looking for. And what we're finding more frequently is that these providers aren't asking the direct question within that time with the patient, are you having thoughts about suicide, or are you thinking about ending your life? And so that direct question's not being asked, and in that very rushed, often, session with the doctor, this information isn't coming out. And so part of the Zero Suicide Project is to help teach medical professionals and also mental health professionals the importance of taking that time to ask that question. In the context of this conversation, that may seem obvious, like why can't we fit in this kind of life or death question? And I think stigma contributes to why that question's not being asked. And then certainly the pressures that are put on these providers to cover a lot of information in the brief time they're with clients or patients. And then this last data point here is a lot to think about. It's concerning, and it also gives me hope. So an estimated 25 to 32 attempts happen for every suicide death. And so a lot of people have a suicide crisis. Something happens, but they're able to get through it and connect to treatment. And there are far fewer people dying by suicide. And so hopefully we can increase our efforts so that there are fewer suicide deaths. And of course we want to prevent attempts as well. That's a big concern, but we'd much rather have people connect to help early and not have a fatal outcome. And so this graph shows the Vermont suicide rate, which is the line on top that looks like some of our mountains in Vermont, compared to the national suicide rate, which is the flat line that has a slight increase that you see on the bottom. And so both nationally and in Vermont, the suicide rate has been increasing over the past 10 years. This is certainly really concerning, and it's especially concerning because there have been more efforts across the country related to suicide prevention. On the other hand, it could be that the number of deaths is actually the same, and we're doing a better job at identifying what is a suicide death. So we have to take that into context when we're looking at this data. It is interesting to look at the Vermont line and to look at 2009 when there was a dip, and also 2012 when there was a dip. And there are lots of different theories about why that is in Vermont, and what I've heard most frequently is that the 2009 dip was after the recession, and the 2012 dip is after Hurricane Irene. And so after a community is impacted by tragedy that's widespread, it is common across the country that suicide rates go down. Unfortunately, since then, the suicide rate has increased to be higher than ever in Vermont, and we're in the top 10 list with countries that are very rural and states, with states that are very rural and states that have a high frequency of firearm ownership. So in Vermont, 1 in 4 families has a firearm. And in a little bit later, I'll be talking about safety related to this, which I say is not a gun rights issue, but is a safety issue. So moving to risk factors and understanding risk, there is not research that indicates what combination of risk factors leads to a suicide death. If we had that, we'd be way better at preventing it than we are now. But what we know is that there could be conditions that are long-standing in someone's life or more recent stressful events that could increase someone's risk to be in a suicide crisis or to turn to suicide. These risk factors could be family risk factors, like having a parent with a diagnosed mental illness, or being separated from someone's family, not having a stable home. Personal or behavioral risk factors, like increased substance use or participating in risky behaviors, or environmental or social risk factors, like growing up in a violent neighborhood, or being exposed to bullying, or being exposed to violence. It's really important to know that there's no typical suicidal person. It's not that a certain kind of risk factors means that someone will turn to suicide. And then, like I said, there's no set of risk factors that are predictive. And the reality is that we all have some risk factors because that's part of life and part of growing up. And these risk factors aren't just indicators of potential suicide crisis, but they could be indicators of potential legal problems or potential substance use issues. And so when we see risk factors, it's a time to have heightened awareness about how someone is doing. If you know that your neighbor, for example, maybe recently lost a job and then loses a family member to an illness and then is having car trouble, that's a lot of stress. That doesn't mean that that person is going to have a suicide crisis, but we may want to show extra caring and concern and to kind of keep our radar up so that if we see warning signs, which I'll talk about in a minute, we can intervene. And so there are specific populations that have increased risk, which is important to be aware of. Lesbian, gay, bisexual, transgender, and questioning youth have a 4 times greater risk of attempting suicide compared to their non-LGBTQ peers. Military veterans have an increased suicide risk. Thankfully, this has had a lot of media coverage, and there are a lot of veteran-specific hotlines or sources of help, including in Vermont, so they can get specific care. But 2 factors that increase their risk are access to firearms and PTSD. Adults over the age of 65 have an increasing suicide rate. Again, that could be that we're calling suicide for that population and kind of fighting some of the stigma there. But health concerns, especially chronic pain, is a big risk factor, and then isolation across populations, but specifically here, is a big risk factor. And for refugee and new American families, risk can be increased because of displacement, trauma, isolation, and again, misunderstanding. And in different cultures and countries, the topic of suicide is understood differently, and so that is important to realize with this population. The flip side of risk factors are protective factors. And these are positive resources or conditions, again, that could be longstanding or more recent, that promote resilience and reduce the potential for suicide. Similarly, these could reduce the potential for other types of risk or illness related to health or mental health. So having particular skills that are highlighted could be considered a protective factor. If a young person is the star of the soccer team, or if an adult participates in a music group, for example, those are specific skills that can help them feel included or feel proud of a skill that they have. Having purpose and value in life, to feel important and included is a protective factor. Personal characteristics like having good problem-solving skills, having self-regulation skills, being able to self-soothe, being able to identify resources on your own, those are personal characteristics that can help someone mitigate risk. Having a safe environment, having a safe home, a safe workplace free of bullying or other types of violence, and then connecting to supports or resources. So if a kid has one healthy adult in their life, that can be a huge protective factor. Sometimes those aren't the adults in the home, and so for those of you who may work with kids or work in schools, you may be that one adult for a young person and not know that. And so it's important to realize that you could be that positive influence. And for adults too, there could be that one neighbor or one friend, one coworker who a person has an affinity with, and you may not know the importance of that relationship in checking in with someone or asking how they're doing. And so a lot of the work that mental health professionals do and that schools are doing and different community groups are helping to increase protective factors, whether they're identifying that explicitly or not. Again, helping people feel connected and a sense of belonging and a sense of participating in the future. And so as we think about balancing risk factors and protective factors, it's really important to be aware of warning signs, which are the earliest observable signs that someone may be experiencing a suicide crisis. Similar to risk factors, there are some warning signs that could be typical adolescent behavior, for example, or considered normative in our culture or society for someone struggling with a stressful event. But every time we see these warning signs, we want to pay attention and intervene. And so the most kind of obvious warning signs, I hope, would be someone explicitly talking about suicide, saying, I'm thinking about killing myself, I want to be dead, I wish I wasn't here. And each time we hear that, whether it's through text or social media or out loud, we need to intervene and express concern and ask someone if they're actually thinking about suicide and mean what they say. Often, because it's become acceptable in our culture to use those kind of words or have that language, someone will say, no, I didn't mean that, I'm having a bad day, or I'm really frustrated. And then the next step there is to say, well, let's talk about that, or tweet about that or post about that, but let's not talk about suicide. That really raises concern. There are other warning signs to be aware of, like an increase in risk-taking behaviors, increased substance use. This could be reckless driving or seeking lethal means like a firearm or medications, giving things away or writing a will, saying goodbye. And then another warning sign that's kind of opposite to these is showing a sudden improvement in mood. Research has shown that sometimes when people have the resolve, have a plan for suicide, and have that sense of resolve for a period maybe of 24 hours or 48 hours before they turn to the means, they may seem suddenly better and kind of out of their depression. And it's important to ask, why are things so different today than yesterday? Again, that could be a good sign that someone's connecting to help and treatment, but it also could be a concern. And you may have heard about the black box label for some antidepressants. There's some theory that is what that's about, that the antidepressant isn't increasing suicide risk, but that someone's starting to feel better when they take an antidepressant and may then have the energy to follow through on their suicide plan. And so typically, for example, when teens are prescribed an antidepressant, their parents or caregivers are engaged in a conversation with the prescriber about having increased supervision and heightened awareness of that increased time of risk. When we see or hear warning signs, if we're physically with the person, we want to stay with them, we want to get help, and it's really important to not keep it a secret. In schools, I'm really impressed week to week with peers who go to their teacher or their school counselor to say, I'm worried about a friend, this is what he or she told me last night or told me just now. That takes a lot of bravery and courage, and it has led to intervention and prevention for many, many teenagers and younger kids in our state and across the country. And then certainly when we talk about suicide, we can talk about risk factors and protective factors. And this question comes up a lot about why. And it's a really hard question because there hasn't been conclusive research about why people turn to suicide. So Thomas Joyner is a suicidologist who's done a lot of research in this area. And his theory has to do with these three tenets in looking at people who have died by suicide and kind of fitting these tenets to what was going on for them before their suicide death. So the idea of perceived burdensomeness, feeling like you're a burden, that could be if you have a chronic medical issue and are relying on a caregiver for the first time or chronically, or feeling like for kids, sometimes we hear the idea of like my parent has to come out of work all the time because I keep getting in trouble at school, that idea of being a burden to loved ones or caregivers. Thwarted belongingness, so feeling isolated or removed from any sort of community group, feeling like you don't belong. And then acquired capacity, which is specifically related to violence and means. And so what research shows is that people who have been exposed to violence and then have lethal means have that increased capacity to turn to suicide as seemingly a solution to what's going on for them. And so Thomas Joyner says that these three things put together, when they intersect, that's when a suicide crisis happens. There are other theories about suicide, but again, there's no specific answer to why. And there is more emerging research to look into this, because this would be a huge help in thinking about suicide prevention efforts, but it's yet to happen. And so also in thinking about the reason why in thinking about suicide, I wanted to include voices of survivors, of people who have survived a suicide crisis or a suicide attempt. And these are both young people, adolescents, and adults who identify feeling hopeless or lost, feeling like I didn't know it could get better. And hopelessness specifically is a really big risk factor for suicide. And then the idea of they'd be better off without me, which certainly speaks to Joyner's idea of being a burden. And then for some people, both young people and then parents or caregivers, the suicide crisis is seemingly out of the blue. Seemingly there weren't warning signs, or people didn't know about the crisis, and then all of a sudden someone's in the middle of a very serious suicide crisis. And in looking back, often people can identify, oh, right, they did make this comment which didn't really make sense. Maybe that was a warning sign, or this has been happening recently, but I thought it was related to school stress or work stress or this other thing. And so for some people, this kind of suicide crisis can seemingly be out of the blue. And so when you're identifying that someone's in a suicide crisis, there's a 3-step intervention. And of course, in training, we say 3 easy steps, and we want to give that message that all of you have the ability to do this. But when actually doing it, it can be quite challenging and emotional. There isn't a script, although we try to give you some ideas of exactly what to say so that you can kind of fall on that when needed. But the idea here is that you're being yourself and you're being a caring person trying to help someone else. And so there is a handout in your folder that has these 3 steps and has some ideas of language of what to say. And the first one we probably use pretty universally as caring people. And so this is not specific to suicide necessarily, although it can be depending on how you approach it. And so this is just saying to someone, I'm concerned about you, I really care. And it could be identifying that someone's really upset or seemingly off or frustrated recently. And so this is just that kind of caring step. And the second step is the one that certainly people identify as the hardest. But it's really important to be direct and asking the question, are you thinking about suicide? You may do that in different ways. You may have your own words or language. You may say, have you been thinking about hurting yourself, or have you been thinking about ending your life? Those are okay words to use when you're approaching this conversation, but it's really important to ask this direct question. And I think sometimes people say they're worried about offending someone, but what I found in my experience, and the first call clinicians have as well, is that people are relieved to be asked directly because they want help most of the time. And if someone's not having a suicide crisis, if you've misidentified warning signs or they're not at that point and you thought they were, most people are pretty honest in saying, no, that's not what I'm thinking about, and can kind of clarify maybe a misunderstanding. So it's okay to ask the question. A lot of people, both locally and nationally, have the misnomer that asking the question can give someone the idea, like that it's suggestive. And so there has been research on this, even for young kids, that shows conclusively asking the question does not give someone the idea for suicide. Certainly in our culture, even young kids are exposed to the concept of suicide in a lot of different ways, and young kids often are aware of the concept. And so when we're assessing really young kids, we may shift our language a little bit in how we ask the question, but it's important to be direct and to ask regardless of the age of the child. And then the third step is to stay with the person and connect them to help. It could be going to the local emergency room together. It could be calling a crisis hotline. I'll give you those numbers in a few minutes. It could be calling an already existing therapist or provider for that person. Or it could be talking to the parent or connecting to another adult who's in the field, in the mental health field or in the know that feels trusted. And so for these steps, these are steps that we often are teaching middle school students and high school students. In Vermont, it's part of a mandate that students get suicide prevention education. And in most middle schools in Vermont, there's part of the curriculum in health class to talk about suicide prevention and the warning signs, and to teach these 3 steps or steps similar than this. So it's important to think about young people having these tools and being able to intervene if they need to. And for those of you who are parents here of young kids or older kids, this could be a conversation to say, if you're worried about a friend, what would you do? And sometimes that conversation can happen in the car when you're not making direct eye contact, and it can feel less threatening. But starting that conversation by exploring with a young person, what would you do if you were worried about a friend? What would you do if there was a safety concern? And you can talk about these steps and the importance of not keeping that concern a secret. And then there is a 4th step. We don't label it as such, but the 4th step really is offering hope and saying that we can get through this, you can get through this, there are people who can help, and you do matter. So often when we do suicide prevention trainings, we talk about myths and then clarify them with facts. And I heard in the past year or so that actually reinforces the myths. So I've shifted my presentation to just talk about the facts. So talking about suicide does not cause it. Almost everyone who attempts suicide or dies by suicide does have warning signs and often talks about it to at least one other person. And again, hindsight's really clear, and so that's why we need to be aware of these risk factors and warning signs and pay attention each time and hold the belief that suicide can be prevented. I want to speak for a few minutes about resources. Help in Vermont looks very different than help in New York in some ways. There's a state-by-state system for connecting people to help. And the goal when someone is in a suicide crisis is to connect them to mental health or medical help as quickly as possible so that a diagnosis can happen if that's appropriate and a treatment plan can be made. And for many people experiencing a suicide crisis, that could mean a visit to their primary care doctor or an appointment with a therapist, and then developing a plan from there. The goal, whenever possible, is to keep people out of inpatient psychiatric hospitalization if that can be safe. And so sometimes when people are in a suicide crisis, you'll hear the idea of a safety plan being made, perhaps so that someone doesn't have access to firearms, or that someone's not driving for a period of time, or that someone has regular check-ins with a provider to make sure that they're safe. In Vermont, we have lots of different outpatient resources, both through the community mental health centers like Howard Center and through private providers. And then there are also crisis bed programs, which can be used if someone's in a suicide crisis, and inpatient psychiatric hospitalization. And so part of what help looks like, and often part of a safety plan, like I was referring to, is what we call means restriction. And so when we're talking about means restriction, what we mean is restricting lethal means for how people attempt suicide or die by suicide. And this little graphic, why, how, comes from the Harvard School of Public Health. And they've acknowledged the question of why people turn to suicide, like I was saying earlier, is really unclear, but how people die by suicide or attempt suicide is really clear. So firearms and medication certainly are two of the most common means. And First Call in our practices has a public health kind of platform that we recommend universally as a prevention measure rather than waiting until there's a suicide crisis and being reactive. So we're always asking families if there are firearms in the home, and if the answer is yes, and again, 1 in 4 families in Vermont has firearms, that they be locked up and that either young people, kids, or someone who's in a suicide crisis not have access. I have been in many homes in Chittenden County, and I've seen many gun cabinets, and that's great, but often the key is right next to the gun cabinet, and that's not the kind of locking up of firearms that we're talking about. So it's important that the parent, or if we're talking about a household of adults, the adult who is not having the suicide crisis has the keys. And it's not that hunting can't happen or that they're always restricted, but always if there are young people in the home, and then for the duration of the crisis. We do have gun locks that we get from local police departments in Chittenden County. At First Call, we hand them out for free to anyone who needs them. We'll deliver them or have them available for pickup. We want to make it really easy for households to access gun locks. And we do have some here tonight. So please take them for your own homes, or if you have friends or family or neighbors in Chittenden County or anywhere that has unlocked firearms, please don't hesitate to hand them out. And then we also recommend safe storage of medications. And often when I say that, people first think prescription medications, but what I'm talking about is all medications, both prescription and over-the-counter. We're in a Costco-sized world right now where people have really large bottles, and if someone's in a suicide crisis, especially if it's that out-of-the-blue suicide crisis, that can be a real concern, again, both for prescription and over-the-counter medication. And so when there are young people in the home, certainly we know kids and teenagers are inherently impulsive. That's developmentally appropriate, but we don't want them to be impulsive in this area. So taking that step, which is a minor inconvenience when you have a headache or you need the medication, to go to the lockbox to access it. And then again, for a household of adults, when there's a specific concern, having medications restricted or just not having those big bottles in the house. And then similarly, restricting access to alcohol. And then we, when we're doing crisis assessments or someone's working with a mental health professional or medical professional, may recommend other types of restrictions depending on the crisis. So there are many resources in Vermont and nationwide to help support people who are in a suicide crisis. One phone number that is really important for everyone in the room to have, so feel free to pull out your phone or your pen to write it down, is the National Suicide Prevention Hotline. The number is 800-273-8255. Again, 800-273-8255. And this national hotline can provide phone support and then can connect people to resources in their community, or if there's an imminent crisis, have emergency responders activated. And so I do want to give you the Chittenden County crisis numbers, but you could be supporting a friend or a loved one in a different part of the country, and this number could come in handy. So I do hope you put it in your phones. In Chittenden County, right now we have 2 crisis numbers that could be important to have. First Call for Children and Families is 24/7, and that phone number is 488-7777. And then the adult crisis team is also 24/7, and that number is 488-6400. And I know the first call number is on the board, but just to say the adult number again, 488-6400. And then I mentioned earlier that there's an app that is, I think, a really amazing tool, and not just for people in suicide crisis, but could be for anyone in to have access to if they're managing stress or even just want kind of a moment of relaxation. And so the app is called the Virtual Hope Box. Again, Virtual Hope Box. It's a free app, and it has essentially an online crisis plan for people to have distractions, to learn coping skills, to do meditation or breathing exercises. You can upload pictures of your pets or your kids or your family or your kind of soothing place when you think about that. And then you can add crisis numbers as well. And so I really recommend that. And for people who you may be working with or living with who don't have access to a smartphone, I've encouraged people to make an actual hope box of kind of a toolkit they can turn to do some of those things as a way of soothing or problem solving when they're experiencing distress. So I hope you'll check that out. And when there is a suicide death or a suicide attempt, certainly we're in a small community and there's really big impact. There can be impact for lots of different types of tragedies, but for suicide specifically, it can bring up both stigma and concerns about what we call clusters or copycat suicides, other people turning to a suicide crisis. And so we think about suicide prevention and then intervention, and after suicide death or suicide attempt, we talk about postvention, the aftermath. And so there are best practices for responding to a family or to a community, whether that be a soccer team, a workplace, a school, after suicide death, and Howard Center has resources to help in that way. So you can call either one of those crisis teams to help with best practices to respond. And again, that can be on the family scale or a larger community scale. And like I said in the beginning, this is a really hard topic, and often I save this self-care slide for the last slide, and I'm thinking about maybe making it one of the first slides, because as we talk about suicide, like I said, different things can come up for us that could be expected based on our personal or professional experiences or unexpected. And so if you do a suicide intervention, you're helping someone that you're really worried about and care a lot about, or just kind of general day-to-day to be best prepared to help someone if they're in a suicide crisis unexpectedly, we would encourage you to use healthy coping skills like exercising or spending time outdoors, playing or meditating, distracting yourself, reaching out to friends or family, loved ones, providing that extra care or nurturing. One example of that is one of the crisis clinicians at First Call, as a way of practicing self-care after her shifts, goes home and has a glass of chocolate milk. Every day after her work shifts, that's kind of her self-care routine and pattern. And I've always thought that's a nice example of just a little way to take care of yourself and have that extra nurturing. Following a routine can be really helpful for self-care, and then certainly knowing your limits, knowing when it's time to reach out to professional help. And often people start with talking to their primary care provider, but other options could be calling those crisis lines, or if you're in a workplace that has an employee assistance program, that could be another option as well. Also, contacting your insurance company to see what options you have for support or treatment in your community. And I'm happy to take questions now. In your folder, there's an index card, so if you'd prefer to write your question rather than to say it, you're welcome to wave your index card and Denise will collect it. But Denise will come around with a mic if you want to ask questions that way as well.
Hi, Charlotte.
Hi, Amy.
Do you have a sense for why the rate in Vermont specifically is high relative to the national rate, and is it disproportionate to certain groups of people?
Thank you for your question. So the theory behind why the rate in Vermont is high is twofold. Compared to our neighbors, we have a higher increase of firearms than our neighboring states. And so that is one big reason that the rate may be higher. The other reason is not conclusive, but is interesting, and that is that we have a medical examiner who's really well informed about the problem of suicide and is willing to call a suicide death, where in other states, potentially based on the stigma or politics or other factors, those deaths may be ruled as an accident or unintentional injury or unknown. And so it could be, unfortunately, that many states have a similar rate, but ours looks higher because we're calling a suicide a suicide.
Hello.
Hi.
You had mentioned about asking directly to a child that might look different than you would ask directly to an adult. How would you address a child?
So for a child, it certainly depends on their age, and not just their chronological age, but also their developmental age. So for example, there could be a 10-year-old who has a solid understanding of death, and there could be a similar 10-year-old who doesn't really have a solid understanding of death. And so what's first important is to get to know that young person, to figure out, have they experienced loss or death before? Do they understand what death means? Sometimes when we're talking to kids, we're hearing about the loss of a pet, and so we can kind of use that as a test example. Or some young kids have lost an uncle or a grandparent, and so helping to understand the context around that. And then asking age-appropriate follow-up questions using their language or words. So it could be starting with asking about worries, and then when they say worries, if they're related to something about suicide or death, kind of going with that. And then asking questions in such a way to double check so that you're not just asking once, but what research shows is when doing a suicide assessment or having that kind of conversation, to ask 2 or 3 times to make sure that you're getting the answers you're looking for. So for some kids, you may say, are you thinking about hurting yourself, or do you ever hurt yourself on purpose? And a kid's answer to that may then lead to the next question of, well, do you ever think about ending your life? Or do you know anyone that's talked about ending their life? To get a sense of their response, and again, taking their lead.
Thank you.
Thank you. I understand from listening that firearms are the #1 means to kill yourself through suicide. Is there any research around the use of knives, swords, or other sharps?
Yes, it's actually very low. So that research has mostly happened by people who research self-harm, or what's sometimes called non-suicidal self-injury. And so beyond firearms and medication, there are other means like hanging or car accidents, drowning or suffocation. And then the rest of the means are like 2% of how people die by suicide. And so for people who turn to something like a knife or a sword, the chances of that being lethal, thankfully, are really low, but certainly it does happen.
My question is somewhat similar. Given the high percentage of people in Vermont who are opiate addicts and have a history of opiate addiction, from what you said, it doesn't sound like a drug overdose would really be a suicide, but is it?
That's a great question, and it's definitely a tricky question because it depends on the context around the death. And so I believe for statistical purposes, a death that is self-inflicted is considered a suicide, but whether it's an accident or intentional would depend on the other factors that are known. So if someone has a note, for example, or if there's other evidence of increasing depressive symptoms, then that could help indicate the circumstances around the death. But certainly there are people who have self-inflicted deaths where it is an accident. Yeah.
Thank you.
No, you need the mic, sorry.
So I hope I can say this clearly. When you talk about things like, you know, this high percentage of people that have seen a primary care doctor and wanting to pick up on stuff in that setting, and also when you look back on people that have made serious attempts, that you find a high rate of there having been warning signs. The question I have is, if you flip it over, you know, how many of people with this collection of warning signs went on to have a suicide attempt? I mean, how specific are these things? Because well, that's really my question.
Yeah, there are many people with many, many warning signs who don't have a suicide death or even suicide attempt. Certainly, there are many people with lots of risk factors that don't turn to suicide. And hindsight certainly is 2020. So after the fact, it could be easy for a medical provider or a mental health provider to say, oh, right, there was this there and it was missed. Or maybe it was addressed, but not in a way that was comprehensive enough. And so it's certainly tricky to be doing research that's based on hindsight. And yet I think in terms of prevention and best care, the hope is that the question is being asked directly, again, kind of regardless of the combination of risk factors or warning signs. Any other questions? Yeah.
Hi. So I had a question. For friends or relatives who lost someone to suicide, what is a good way to offer help and support, and what would be a less helpful way? So what kind of language is there to use?
So it really depends on your relationship with the person you care about who's experienced that kind of loss. But again, I think because of the stigma around suicide, it's hard for people to talk about. And often that means that people who are impacted by suicide loss may experience increased isolation because people aren't sure how to reach out. I would say as a culture or as a society, we don't do a great job talking about death in general, regardless of the reason for death. We kind of stumble over our words. And so I think when there's a suicide, that's even more so the case, that people worry about bringing it up or talking about it, acknowledging it in some way. And what we've found, both through the Suicide Prevention Coalition work and then at First Call when we've supported people who have had a suicide loss, is that, again, they feel relieved when someone is willing to have the courage to say, I really care about you and I'm sorry this happened and it's okay if you want to talk about it, and creating that safe space. Certainly there could be people who aren't ready to talk about it, and it may need, a similar conversation may need to happen in a week or a couple weeks or even a couple months. And there are some people who right away may want to talk about their own feelings of potential guilt or concern, and may need some support in figuring out how to connect to professional help or in other ways. So I would say don't be afraid to directly ask and invite the conversation and to say I'm willing to talk about it if you want to do that. Yeah. Any other? Yeah.
Hi, Charlotte. This was really informative. Thank you.
You're welcome.
For clinicians who are not crisis clinicians, but who may be working with a client who has suicidal thoughts, what would you say are the most important elements of a safety plan that they would construct together?
Thanks, Matt. The first thing is that the zero suicide model asks that clinicians ask their patient every time if they're thinking about suicide. That's really not done in mental health practice. It's sometimes rare that people are even asking on the first visit. I hope we're getting better at that. But to ask every time, I just want to check in, are you having any thoughts about suicide? A lot of people think that's overdoing it, but again, we're talking about life or death. So the zero suicide model would start with making it a regular part of the conversation. That could help within the context of therapy or in working with the clinician, remind the patient or the client that it's okay to talk about it in an ongoing sort of way, not just in the initial session. And then in terms of a safety plan, the best kind of safety plan is really driven from the client or patient. What would feel safe and supportive to them? What do they think is possible to help keep them safe? often we're talking about means restriction when we talk about a safety plan. If someone doesn't have access to means, their chances of attempting suicide or dying by suicide certainly go way, way, way down. And most specifically, firearms and medication. But again, having the young person or adult identify what would help them feel safest. And so at First Call, working with teenagers and talking to them about a safety plan, sometimes they'll suggest, well, why doesn't this get put away for a little while? Why don't the knives in the kitchen get put away? That may not have been part of their suicide plan or have even come up, but that's helping them feel a sense of safety or reassurance. Beyond that, I think having distractions that could look like coping skills or ways of self-soothing in an appropriate or healthy way. And so that could be taking a walk with a friend or loved one, listening to music, coloring, or doing something tactile with your hands is often part of a safety plan. And then having contacts to reach out to and access to those so that if someone has increased symptoms or an intensity of their feelings of suicide, they aren't going through that alone but can reach out. And often those contacts could be a friend or a family member, a loved one. Sometimes that's a crisis team or an ongoing provider.
A question about actually attempting to take a person attempting to take his or her own life and succeeding. Where do you draw the line between a person who, whether an adolescent or an adult, who's impulsive and doesn't take quite enough? Or is that also considered a suicide attempt, or would it be diagnosed differently?
Like someone who has an attempt that's not fatal or lethal,
Right.
or considered maybe medically serious. So like the data shows, for every one suicide death, there are as many as more than 30 people who have attempts. And what's considered a suicide attempt could be really, really broad. So I think in the movies or in the media, we see people kind of waking up in a hospital bed afterwards or something really dramatic like that. But there are lots of people who might have a suicide attempt who may never go to a hospital and would have maybe a session with an established therapist, may have a crisis outreach in the community, and may be able to connect to outpatient supports and not need hospital level of care, as we would say, that kind of intervention. And so a suicide attempt is whatever someone thinks a suicide attempt is, and we need to take that really seriously. So I think kind of the classic example that we talk about in the kids' crisis world is a kid jumping off a bunk bed and saying that was a suicide attempt. We all know that that's not lethal, hopefully if the bunk bed is a typical height, but if they think that that is a suicide attempt, we want to respond with caring and concern to figure out what was contributing to that moment and how to connect them to help. So we don't want to minimize it or dismiss it because we know that that's not lethal. And at the same time, we don't want to be overly reactive and to say that this is a suicide attempt survivor and may need a lot of treatment and support, but respond at the level that that person is presenting their suicide crisis and then treat it accordingly. So there are lots of suicide attempts that aren't what we would say need medical intervention. Any other questions? Thank you all very much for coming tonight.
Thank you, Charlotte.